up to the minute, update that we've provided in a while. Although I think you'll note as I share my slides um, that I have not my slides are not up to the minute because we actually had some developments just this week that I haven't added in here. I'll mention them as we get to that point, but you'll just have to recognize that that such is the case, and that even though it says March 31st in a couple of these slides, that we actually have now had an extension of the telehealth policies until September 30th. So anyway, welcome everybody. If you haven't been to one of these updates before, and even if you have, you're going to have to sit through it. We're going to talk just a little bit about who we are, with after first noting that, of course, we have been doing these policy updates for a while at the beginning of every year. This year it's different because each month has been a little different. When we were doing these updates in March, I had to note that, hey, March 31st is a big date. Well, now it's been kicked down the road to September 30th, but it still applies. The we're still under flexibilities temporarily, and so I'll note that as we get going here. We are the Great Plains Telehealth Resource and Assistance Center. Mary, myself, Zoe Hills, if you've met her, the three of us make up the GP track. We are housed officially, administratively, at the University of Minnesota in the Institute for Health Informatics. We're a funded project paid for by the Health Resources and Services Administration of HHS, a federal grant. There are 14 telehealth resource centers around the country. 12 of us are regional. You can see the regions on the map there, and you can see our region in the upper middle there. We cover all the states surrounding Minnesota as well as Minnesota. So that includes Nebraska, North and South Dakota, Iowa, and Wisconsin. And that link at the top, www.telehealthresourcecenter.org, that will lead you to all of us, to a national website that has all of our websites there, and you can get lots of information from all of the telehealth resource centers. You don't have to just talk to us. You can talk to any of them. If you talk to us, you're probably talking to all of them too, because we talk with them all the time. We share questions, we share queries, we share resources. We work together on everything. So, but the best way to contact us probably is directly by email. Ask your question, let us figure out exactly what you need to know, and then let us help you find what resources you need to address that. We, like every TRC, keep a bunch of resources online at our website, gptrack.org, including some policy pages. We summarize Medicaid, commercial, other rules. We try and keep those up to date as much as possible. Let us know if we've missed something. We also have billing guides that you can download. Our current one was updated January of 24. Pretty up to date. There are a couple things that have changed in Nebraska that aren't reflected there, but they're mostly little details that changes Medicaid made in the last couple of years that I'll mention here in a minute. We are going to break this into a couple of different sections. We want you to understand key regulatory issues that are in play, and then also understand how those apply to you, those policy changes apply to you, but also how they happen so that you can kind of be aware when you hear news about this or that. One of the most frequent confusions we have to address is people understanding or thinking that all telehealth is regulated from one set of rules. And that's not the case. When CMS changes its rules, it only affects Medicare, et cetera, et cetera. So we'll talk about federal updates. We'll talk a little about state after addressing a little bit of the regulatory context. So sorry if this is repeating for some of you, but there are rules at the federal level. There are also rules at the state level. And also what you can and can't do with telehealth is different than what you can or can't get paid for. Those are two different categories. What's legal via telehealth is pretty much regulated at the state level through licensure. Okay, what you can or can't do legally as a psychologist or as a clinician, as a physician, as a nurse practitioner, or whatever, And for the most part, those licensing boards say, hey, whatever you can do, whatever you're qualified to do through your licensure in person, if it makes sense and it's ethical and it's secure and all of those things, and you get proper consent, you can do those professional things through telehealth. There are a few federal regulations, of course, that apply, basically healthcare regulations generally. So, anti-fraud, security, HIPAA, those kinds of federal regulations apply to all of healthcare, and telehealth is healthcare. There's also the Ryan-Haight Act, which we'll talk about more later on, that limits prescribing of controlled substances online without a prior in-person evaluation. But we'll get into that further. I just want to draw the distinction between federal and state, and at the state level, most of the regulations are through licensures. Why your clinicians are so nervous about telehealth, because it's their license that's on the line. There are a few things that states add sometimes to the feds to say, you can't do this by telehealth or you can't do that. But in general, it's through the licensure. Um, what's reimbursable, so what you can get paid for by telehealth is different than what you can or can't do. Any of us in clinical work know this. You can do a lot of good things that are legal to do, but if you can't get paid for them, you're probably not going to do many of them, even though they might be helpful, because we have to remember, we have to figure out how to get paid for what we do. And so those policies vary payer by payer. Medicare is national. What they cover or not is national. State Medicaids are, apply within the state. And then, as you know, commercial payers can vary by plan, but often have a sort of general set of policies that they'll institute across all of their plans, some of the plans being a little more generous than others. So what's new in 2025? Some things have been made permanent in the past year, and others are at risk of going away. They were at risk on March 31st, but now that's been extended to September 30th. But let's talk about the state level first. The folks in the Nebraska legislature have not been idle, and we have a few specific things in the last couple of years. This past year, they adopted several interstate licensure compacts, and I'm not going to spend the time to go into the details of each of these compacts. Each one, of course, applies to a certain set of licensees certain within Nebraska, and many of them have differ in their exact policies. If you know about licensure compacts, there are probably two that most people know about. One is the nurse licensure compact, which is what I call a true compact. You have one nursing license in one compact state, and you can flash that nursing license in any other compact state and legally work as a registered nurse. It's great. There's an enhanced version of it now that most states have, who were in the original one, have also ratified. So good on the nurses. They're doing it in a very effective way, in my opinion. The other one that most people have heard about is the medical licensure compact, but it operates completely differently. Okay. And the point I'm making here is that each of these compacts is a little different. So before you dive in and think you understand them, make sure you dig into the exact one that applies to the exact license you're thinking about. The medical licensure compact is really a facilitated multiple license setup, whereas you apply for a medical license in one compact state, they will forward on your materials to other states to facilitate your application for a license in that state as well. It's not one license that works for all of them. You need a license in every single state. It's just that the compact facilitates getting those licenses. All right, makes it a little smoother, a little more streamlined. So that happened in this last year in Nebraska. Second thing, payment parity for telehealth if in-person services are also provided. That is, if you're a provider that also works in Nebraska providing in-person services and you're providing telehealth services, you're getting paid parity. Okay, it's a little detail, but it's not unimportant. Okay, so we've got the last little sort of niche bit of parity added that was missing before. There are also some rules, and these were passed last year, some rules about ensuring access to telehealth for folks who are incarcerated in the criminal justice system. So another little corner case, but a significant change for those it affects. And then there were a couple of provider bulletins, some updates. Um, One of them updated to add PT, OT, SLP providers, physical therapy, occupational therapy, speech language pathology providers to the list of payable providers, adding SUD care and service and behavioral health services to available services, and then updating the provider manual commensurate with those changes uh, so that it would line up. I mean, there are multiple reasons here, but one of the reasons is so it would line up with the federal Medicare coverages because those providers and those services are covered under Medicare. So those are changes. They're not huge, but they're not nothing. And so I wanted to just review those quickly. This slide, as Mary said, the slides are coming. These links are all live, and so you can dig into these links a little further if you want to find out exactly what they say and what the differences are. The billing details there at the end of the first paragraph, just the 2308 bulletin was about adding uh, uh, place of service to and 10, the telehealth, a telehealth place of service and a patient's home place of service, as well as modifiers 93 and 95 for audio and video. Uh, uh, and then the other one, the later one for ending coverage for end-stage renal disease and vent services and pulmonary rehab. These were some flexibility services that went away, and then adding the PT, OT, and SLP and SUD services. All right, you can dig into those as you see fit. One other thing I want to just call out because it is unusual for Nebraska, and if you're working in telehealth in Nebraska, you probably already know this, but Nebraska requires certain elements in a consent for telehealth. They don't require a separate consent. In other words, these elements can all be incorporated into your overall omnibus patient consent form, but you just need to make sure that these elements are in there. And in case you want to, Nebraska provides an example, a sample consent that you can use. The form on the right is just a screenshot of that consent. You can download it. You can find it at the link at the bottom of the slide there. But you don't have to use that form. You just have to make sure those items are in your consent so that people know when they're using telehealth, they have these rights and that these items are part of a telehealth encounter. So something to just remember as you're doing telehealth in Nebraska. All right. The bulk of the time we're going to spend talking about federal updates and just differentiating how they work and what's happening here at the federal level. Some of you probably have heard about the extension, and we'll talk a little more about that. If you'll recall, during the public health emergency early in the pandemic, 3 sets of flexibilities were implemented: Medicare, HIPAA, and DEA. At the end of the public health emergency, when that finally ended last year, the HIPAA flexibilities went away. We all had to get HIPAA compliant right away, which we should have been already. The Medicare flexibilities were extended by an act of Congress because CMS can't do it once the emergency is over. CMS can no longer extend flexibilities on an emergency basis because there's not an emergency. The emergency has ended. So Congress extended those, and they've extended those a couple of times. And the DEA also does have the capability to extend and change its policies, and they have extended their policies a couple of times as well. DEA said, "Hey, we're going to take them away" last year, and then there was an uproar about that, and they said, "No, no, no, okay, we'll leave them in place." And in fact, those flexibilities still are in place. The DEA flexibilities are in place until the end of 2025. So even though in the meantime DEA has made some permanent changes, those changes are still overshadowed, overruled in a sense by the flexibilities currently in place. Don't worry, we'll say a little more about that. And the Medicare flexibilities were to end the end of March. They have now that can's been kicked down the road 6 months, so end of September is where we're going to be. That's the next drop dead date for the telehealth flexibilities. And we'll talk about exactly what's at risk there. So what's at risk after September? Well, specifically, medical care under Medicare. Okay, so and we'll dig into this a little further. Medicare will, if they go back to previous rules, Medicare would no longer cover uh, non-rural locations. Remember the original rules, if you remember them, uh, the patient had to be at a healthcare facility, not at home, and that facility had to be in a rural area. So those rules would come back into play. Right now, we're still flexing. It's like patient can be at home, patient can be in a rural, urban, suburban. It doesn't matter where the patient is at the time. Okay. The second flexibility is that we can use any technology now. Before the pandemic, audio only was not a thing. I mean, it kind of was in a few small areas, but we didn't do telehealth over the phone. In fact, telehealth over the phone was specifically excluded from the Medicare rules. The statute excludes it. Uh, and so the statute, if it goes back into play, we can't emergency flex. We can emergency flex out of it. We can't, CMS can't flex that rule outside of an emergency without congressional permission. So if the congressionally mandated flexibilities go away at the end of September, then we'll be back to live video only. Also, a bunch of new providers, including specifically FQHCs and RHCs and PTs, OTs, and SLPs, have been added to billable providers. Would be back to physicians and nurse practitioners and PAs, clinical psychologists, and clinical social workers like the original regulation. There are a number of other programs like the Acute Care Hospital at Home program, hospice research by video. Annual in-person visits have been suspended. So those flexibilities also would go away if the flexibilities expire in the end of September. Some other things just to remember that are already gone that were flexed during the PHE: first dollar telehealth coverage for high deductible health plans and health savings accounts. People who use those mechanisms to pay for health care could apply them for non-covered telehealth services by law. That's gone away, and so now it varies. Whatever the policies of the plan are in place. And then there were a couple of cardiac and pulmonary rehab services that were available temporarily, and now those are done. Also, though, and this is important to remember, some services under Medicare, this is all Medicare, have been made permanent and don't need to be extended anymore. Specifically, we're talking about behavioral health services. Behavioral health services, as paid for by Medicare, can be provided from anywhere, the patient's home, non-rural locations, wherever, and they can be provided using any technology, audio or video. And that's permanent. That's permanent CMS policy. So as permanent as anything gets in CMS. So those things aren't going away regardless of what happens at the end of September. FQHCs also can be reimbursed and get coverage specifically for behavioral health services, for telebehavioral health services, same as in-person care. That's another flexibility that CMS, this is pushing the boundaries of what a regulatory agency can do, but they have decided that fits within their remit, within their mandate, and they have made FQHCs and RHCs permanently available or permanently able to bill Medicare for telebehavioral health services, not medical services. And there's a little bit of nuance there we'll get to in a minute, but behavioral health, that's permanent. All right. This is probably redundant at this point, but just trying to recognize where's the change coming from. I think by now we've kind of realized it's not the state. The state and state Medicaid is moving along at its pace, what it does. CMS is making its regulatory changes per schedule. They just released the physician fee schedule a while back, end of last year, and it's in place now. The changes that we're talking about are all under Congress's control, and they are things that CMS can't do. CMS can't extend. Likewise, when you think about the three groups of payers, Medicare, Medicaid, and everything else, commercial, self-pay, sliding scale, all of that kind of stuff, the only changes are happening under Medicare. Okay, the other payers stay intact, although Medicare has a lot of influence, we know, but the other payers are not affected by the changes at the end of March or at the end of September now. The other thing to recognize, and this is what I just was saying in the last few slides, if you split Medicare into primary care and mental health, the changes are in medical care, not primary care, not just primary care, but all of medical care. They're not in behavioral health. Behavioral health, mental health has been extended permanently. Medicare Advantage is still a question. Is it Medicare? Is it commercial? There are commercial plans that are paid for by Medicare. Is it going to go back? How's it going to fall in this? I have not heard a good analysis of that. And so your Medicare Advantage patients, those payers are going to probably sort of decide for themselves whether they're going to treat themselves as Medicare if the flexibilities go away, or if they'll treat themselves as commercial payers if and when the flexibilities go away. Um, you got 6 months before this is important now, but I wanted to keep it in the slides so you have access to it because what counts as an originating site, as a rural originating site for Medicare, is critical if the flexibilities go away. And there are a couple of different places, and sometimes it's confusing. The site at the bottom, the MI rural site, is a great one if you're going after grants. It has lots of information in there. The Medicare originating site stuff is in there, but it's hidden and it's kind of confusing. And so I just don't go to that site. Don't use that if you're trying to find out whether you're eligible for Medicare originating site payment. The top site there is the Medicare Coverage Analyzer site, and that's the place to go to put in a street address. That's where it has to be an office of some kind, a facility, healthcare facility of some kind, where the patient is sitting at the time of the video encounter. And if it is rural, if it comes up yes using this tool, then Medicare will cover that service. If it doesn't come up yes, Medicare will not cover the service originating from that site. All right. The physician fee schedule this year. It's a little interesting. As usual, Medicare made some changes. They've done some interpreting things differently, like they have been want to do over the last few years. But let's just go through some of the things that CMS made permanent in this year's physician fee schedule. That's 2025. We're under it now. We're operating at this. These are the rules of Medicare right now through this year. Audio-only services can be used for any Medicare service that's covered. Okay, this doesn't say that it's covered. It's just saying that it's a valid format for providing telehealth. Medicare has added audio only to the definition, the technical definition of what counts as telehealth. Okay, they haven't said it's covered always, because we'll go on to some of those details, but they've just said if it's covered by telehealth, it's covered by audio only, basically what they've said. Okay, couple of conditions. The provider has to be capable of both audio and video. There's no phone-only doctors, no phone-only services for Medicare. You have to be capable of doing video as a provider. Patient doesn't have to be, but the provider does. The patient has to be at home in order to use audio, and either they can't use video or they don't want to use video, which is a pretty broad net. I mean, basically, it's up to the patient. Do you want to use video or audio? If they don't want to use video, you can use audio if they're at home. All right, and Medicare CMS has told you 93 modifier is for audio only, unless you're an FQHC, and you use place of service 10 for the patient's home. Okay, nothing other special other than what you would normally put in telemedicine documentation. So this is a change to the definition of what a telecommunications system is. Again, it doesn't guarantee any coverage for any type of service. It just says if the service is covered, you can use audio only for it if the patient's at home, and you can do video. The other thing CMS, the physician fee schedule included this year, is that they just carried forward all the provisional telehealth codes. They didn't make any changes. So this is to ensure providers that as long as the flexibilities are in place, as long as you're covered as a provider to bill Medicare, then your codes that you need to cover, the codes that you need to bill to provide telehealth, are also available. This is primarily for audiology and SLP, PT and OT, some of the services that are being, the providers that are being flexed in, they also need codes to bill for their services. And so those are continuing to be flexed in. Although this isn't a flexibility, this is CMS just decided we'll just leave those codes on the list this year because those providers may be billing those services. There's a link at the bottom there. That's a link, table 12. That's the official CMS list of all covered telehealth codes. They keep it up to date every year. You can click on it, find it. You can search it and find it. It's a good tool to have on a link so that you can look up any specific code you might be questioning whether or not it's covered. Another thing that the physician fee schedule did this year is that, and this wasn't CMS actually that instigated this. This was the AMA. The American Medical Association owns the CPT code manual. Okay, they're the copyright holders. It's a little cash cow for them on the side, and also a great service to the medical community. But they want codes for everything a physician or a healthcare provider might do in an encounter. And so they are continually updating codes and creating codes. And of course, a lot of things have happened in healthcare in the last few years. So we need some new codes. The AMA has decided, hey, we need some telehealth codes. And so they published 17 new telehealth codes. Now, CMS, the payer, said, yeah, we don't need to cover all those codes. We don't cover all those codes. That's a lot of stuff that we don't cover. There is one of those codes, though, that we do cover. And we've been using G2012 for it. I suppose we should use the CPT code since it's available now. And so Medicare just said, G2012, we're not going to do that anymore. We're going to use 98016. It's one of the new AMA codes, new CPT codes. Works great. It's the exact same thing that we've been covering, the virtual check-in. It's a phone call before an appointment or it's at least 3 days before. It doesn't lead to an appointment within 3 days, and it doesn't isn't a follow-up to an appointment within the last 7 days. It's a virtual check-in. If you can look that up the definitions of it. But so that's a new code that CMS is recognizing in Medicare. A little side note here, and if you don't quite get this, you can follow up with it, and I can explain it. It's a little bit of a esotericism here, but it's these codes, the virtual check-in, there's a number of other codes that are not strictly telehealth according to Medicare. They're not covered by the flexibilities. These are permanent. They're not part of the telehealth codes. A telehealth code for Medicare is something that needs POS 10 or POS 02 and is otherwise an in-person CPT code. Okay. This is not one. There is no in-person version of 98016. There is only a virtual version of that. Okay. So it is not a telehealth code according to Medicare. I'll leave that there and move on. It's a minor point, and if you for some reason find yourself needing clarification, just follow up with us. We're happy to do that. The telephone E&M codes kind of went back and forth during the PHE 994412 2 and 3. CMS deleted them, or the AMA actually deleted them when they made these 17 new codes. And CMS said, yeah, we'll just pay those as a bundled service. The reality is they don't pay for those. And it's not because they're not paying for those services. It's because they don't need those codes to pay for those services. CMS pays for those services a different way. That is, through billing an E&M code with a modifier. That's how you bill a telephone E&M service, not using the 99441, 2, or 3. Those codes don't exist anymore. So, when CMS says those services will be paid as a bundled service, that's not really how it's going to work practically. How it's going to work is you're going to see a patient, do a telephone E&M because they can't do a video or whatever the reason is, and you're going to bill your E&M code that's appropriate for that length of service and complexity of service, and you're going to put a modifier 93. For this year also, the visit frequency limits remain waived. So there were some visit frequency limits for telehealth, subsequent inpatient visits, subsequent nursing facility visits, and critical care consultations by video. They were limited to 2 or 3 a week. I think it's 3 a week. And so those frequency limits remain waived for this year if you need to do more than that. Also, this is a pretty significant change, and I think it was also already more or less permanent last year, but the use of video to make supervisors available for direct supervision. What's called direct supervision is a technical term for it. Need to be immediately available to intervene, but immediately available via live video counts as a way of being immediately available. So uh, um, uh, for services that need immediate supervision, live video is a possibility there. Also, incident to services, other kinds of services that need supervision. Um, Also, in training settings where the attending needs to personally um, participate in the encounter, if that encounter is virtual, the attending can participate virtually as well. They don't have to be sitting next to the rendering provider or the resident to be present at a virtual encounter. They can beam in from wherever they are. So the CMS has just made those, continued to make those a permanent part of how it's going to manage virtual care in a supervisory setting. Also, CMS put a little Easter egg, a little. This is a kind of a temporary fix, but in case the flexibilities go away, CMS made a way for FQHCs and RHCs to bill for medical telehealth. They gave them a new G code for that, the 2025 G code for medical telehealth services. Now, as long as the flexibilities are in place, FQHCs and RHCs can bill the normal way for E&M services and get a PPS rate from or an AIR from CMS. But if those flexibilities were to go away, then they would bill this code. This code is going to be paid in a calculated rate of a few other codes. CMS has done this before. It's probably going to be lower, probably significantly lower than a PPS rate. But it is, like I say, a stopgap, and it only applies if the flexibilities go away at the end of September now. And it doesn't affect behavioral health at all because behavioral health is already allowed at FQHCs permanently. There are also some changes to opioid treatment programs. Actually, I shouldn't say that. They are flexibilities that have been made permanent under CMS's rule. These opioid treatment programs and controlled substance prescribing in general, this kind of gets regulated from three different directions. All right, CMS law weighs in for Medicare, SAMHSA weighs in as a regulatory body, and then the DEA weighs in as kind of, hey, this is our home turf. This is what we regulate. And for opioid treatment programs, at least temporarily till the end of this year, these three are in alignment, and they're basically the same rules as have been in place for the last 3 or 4 years. Okay, the same flexibilities. That is, you can use video or audio to initiate Suboxone treatment for opioid treatment in the context of an opioid treatment program. It's an interesting distinction here. It's not just Suboxone anywhere, and it's not just controlled substances anywhere because CMS knows they don't regulate that. But from CMS's perspective, it's in the context of an opioid treatment program, initiation of Suboxone can happen over audio or video. Video is still required for initiating methadone treatment. And so Medicare as a payer is kind of covered. SAMHSA basically has the same policies. We'll talk about what DA is doing in a minute. Other changes for 2025, the Q through for the originating site facility fee, it always gets bumped up a little bit every year, so now it's at $31. Place of service 10, the patient's home, continues to be paid at a non-facility rate. This is a continuation of a policy that's already been in place, and I won't go into details. It's a little higher rate for patients, even though they're not in a facility. Providers can use their practice address as their distance site location during an encounter. So on a billing form, when you have to say, where's the patient? The patient is located at such and such. Where is the provider? There was a big hubbub about, do they have to put their home address if they're working from home and seeing patients by video? No, they don't. They can put their practice address. Now, they need to have a practice address. If they do more than half of their work from home, then their home is a practice address, according to CMS. But if you're just spending Thursdays at home seeing patients by video because that's Thursdays your telemedicine day or whatever the arrangement is, then you can continue to use the office location, the practice address as the distance site location. There are also some new advanced primary care management codes. The care management codes are a whole class of codes: chronic care management, collaborative care management, transitional care management, principal care management. There are a couple others, pain management. Um, these are all paid on a monthly basis at a certain rate, and they allow a lot of technical flexibilities, team-based care. Unlicensed folks can even provide part of the care, supportive care. And so CMS is just adding the advanced primary care management codes to this list of codes, and that can be paid in addition separately from a PPS rate for patients in an FQHC or RHC. It's a cool program. I'm a big booster. I love it. Follow up with us if you have more questions about the whole care management model and how it works. And then there are a couple of new interdisciplinary consultation codes. As you know, the doctors got a code last year where a consultation between physicians could be billable with the patient's consent. You always got to get consent if you're going to bill the patient. The rest of the healthcare community got a little love this time around, and CMS added some codes so that non-physicians can also do interprofessional consultation with patient consent to provide enhanced care that way. All right, let's talk about the DEA. Policies for 2025. This is kind of, there's an overriding flexibility here, still in place. This is so confusing because DEA comes out with new permanent policies that are effective today or effective in February or March. Yeah, they're effective, but the waivers are still in place until the end of the year. So permanent policy has been changed permanently. Wink, wink. But the current policy is still a waiver. So, and the waiver policies are the ones you know and love that are already in place that we've already talked about, where all controlled substances, all schedules 2 to 5 can be prescribed by telehealth without an in-person evaluation. That's a waiver versus the Ryan Haight Act from '08. Okay, that waiver allows that to happen. DEA registration has to be maintained in at least one state, which is different than well, you'll see. One state is all you need, is what this boils down to. Your home state is enough, or your home work state, whatever that is, one registration. And this is, like I say, a waiver against the 2008 Ryan Haight Act. And that is the policy. That is the rule. That is the law until the end of this year. Now, underneath that rule, underneath that waiver, permanent policy has shifted, but it's not affecting us yet, although it went into effect in February or March. They moved that date. The February 18th date was moved to March 20 or 21 or something. But still, it's not actually in effect because of the waivers, and it is more restrictive than those waivers. Only Schedule 3 to 5 is covered. So all the good stuff on Schedule 2 is different. The pharmacist has to verify the patient identity in addition to the provider verifying patient identity. And there's a lot of PDMP reviews that have to happen. I'll talk about this a bit more, but basically documenting a review of the PDMP, and if it's unavailable, coming back within 7 days and documenting it until you get that documented that it's been checked. And even then, after all that, you can only do a 6-month supply before you do an in-person evaluation, before an in-person evaluation is required. So quite a bit more restrictive. So it would still require an in-person eval. It's just kicking the can down the road 6 months. You can kind of bridge to that in-person eval. Doesn't really take into account the fact that so much healthcare is being provided 100% virtual anymore. But that's the critique that many are raising. And it could lead to things like just, switching doctors every 6 months or other sorts of workarounds, creative workarounds. There are 3 DEA rules that are out. That one that I just talked about. There's also a DEA final rule for Veterans Affairs, which is very similar to the one we just talked about, except that in the VA, a VA provider can rely on the in-person exam of any other VA provider, any other qualified VA provider. So there you go, get out of jail free card in the VA because you can rely on any other VA doctor's in-person eval. Although it's still, you still have those PDMP reviews that you have to document. And if you can't document it, you only can give a 7-day supply and you have to come back and document it. So there's a lot of PDMP still in the DEA rule. There is also, okay, so those are the two kind of general rules. Then the DEA also proposed a rule for special registrations. This is the rule that was originally mentioned in the '08 Ryan-Haight Act. It was re-emphasized in 2013, I think, in another law where Congress said, hey, remember that thing we told you to do back in '08? We're telling you to do it again. You really need to do it. And last year, the DEA said, oh, you know, that rule you told us to do twice, we're not doing that. Well, I don't know, somebody got taken to the woodshed or what, but the DA now has the rule, or at least the proposed rule. It's in 3 levels. The first one is the standard telemedicine prescribing registration. So if you're a qualified provider, a prescriber, you can apply to this registration. You can get this registration, and it will allow you to provide Schedule 3 through 5 controlled substance prescribing without an in-person eval. Okay? It's not nothing, but it's not really what we want. What we want is the advanced telemedicine prescribing registration. That's the second one there. That one allows Schedule 2 through 5. Okay, so all of those narcotics and stimulants and the things that really are at issue in prescribing. There are a couple of caveats, though. You can apply to that and you can get it scheduled. However, you have to be located in the same state as the patient at the time that you write that prescription based on this registration. In other words, you're doing a telehealth encounter, you haven't seen the patient in person, you haven't evaluated them in person, you're going to prescribe a Schedule 2 medication. You have to be in the same state as the patient. The provider has to be in the same state. And they can only use this registration. These circumstances can only obtain these virtual evaluations and prescriptions can only be half of all of your Schedule 2 business in any month. Okay, that's a pretty severe restriction as well, in my opinion. So these are the caveats out there. This is a proposed rule. It's not finalized yet, but people are commenting on it, and we expect to see some revision and some finalization eventually. The last one is this platform registration. The DEA says, hey, a lot of this prescribing goes on in telemedicine platforms, which is a little bit of a vague concept, but basically they're, you know, the Teledocs and the American Wells and the virtual platforms that don't have an office, that don't have a bricks and mortar somewhere, that also might be prescribing, through which you might be getting a prescription for, a patient might be getting a prescription for a controlled substance. Platforms also need a registration in addition to the providers who work on those platforms needing registrations. Okay. And the PDMP checks get worse, expand. 3 years from now, you're supposed to have a national PDMP check. We don't even have a database to do that yet. But DEA folks, they're such optimists. They think we're going to have one, and so great. They are going to require that. Also, there will be these special, you will need to have a special telemedicine registration for every state that you work in. In other words, every state where there's a patient that you see. So all of that's part of the proposed rule for the special registration. So I just wanted to lay that out and make that as clear as can be. It's probably going to change sometime this year, and we'll just have to keep an eye out for that. All right. That's the end of the updates that I have. We'll have time for questions. I just wanted to point out a couple of things that we also have. A couple of other resources that are available to you. One is the national website, of course. Again, I mentioned this earlier. In addition, the Center for Connected Health Policy, CCHP, at cchpca.org. They are the telehealth policy resource center. And so they have policies, and they keep a close eye on all these policies as they're developing. They do a lot of rapid response kind of work, and I just want to make sure you know about their website. They also, and this page kind of calls out, they also have a special set of policy resources specifically targeting FQHCs. So that's available if you're one of those folks and you need that sort of thing. Lastly, I want to call out that almost everything we do is free. And of course, if you call us up and ask us questions, email us, all of that is free. The only thing that we do that isn't free is our conference every year. We This is a fascinating opportunity. It's a great experience. We get a lot of people there. It's a lot of fun, and it's a lot of information. It is operations focused. So we have some providers show up, a few executives, a few payers. It's a mix, but mostly it's operations people, the people who are tasked with getting the work done, running the clinics, running the services, solving the problems to get patients seen according to the regulations that are in place as they move around, and getting the services paid for as the payers shift policies. So it is focused on operations for telehealth. It's April 22, 23. You can get more information at gbtrack.org/conference. Would love to see you there. We are covering not only our 6 states, but also the 4 states of the upper Midwest, Illinois, Indiana, Ohio, and Michigan, and the 3 states of Heartland, Kansas, Missouri, and Oklahoma. So all 4, 7, 6, 13 states are going to be represented there at that conference. We'd love to see you there. Please take a minute and check that out. All right, that's the shameless plug. And this is my contact information if you need to follow up. I will go ahead and stop the share there, and we will go to questions.
Yes, and I can respond actually, excuse me, to the questions that we currently have posted in regards to access to the recording and the digital handout. Basically, the digital handout will be a copy of the slides. Those will all be sent to everyone who has registered for the webinar, and a link to those will be included there. They will also be posted on our website, link to the YouTube recording, as well as the link to the slides. So they will be coming out probably in a day or two. It won't be within the next few minutes, but it will be within the next week. So.
All right. So I think then, if there aren't other questions.
Please do feel free to, if you have a question that is not, that you would rather not type, raise your hand, and I will be happy to open up your mic so that you can ask your question live.
Well, then we will take it that there aren't any at this time. I will also underscore the best way to get a hold of us is by sending us an email, calling us on the phone, get us, what we have found over the years is that every question is a little bit different there. And people ask, well, what about, I just need to know whether this service is reimbursed or not. Well, what kind of a facility are you? What are the payers that we're talking about? I mean, there's always details that you may not realize make a difference, but they do. So reaching out to us is always a better way to get information. And we're not trying to sell you something. We're not going to twist your arm. We're not going to say, "Oh, hey, sign up for our new mattress or or whatever." We work for free. We're paid already. So reach out to us and let us know how we can help. So that we can get this information out and get it in a usable form so that you can apply it wherever you need to apply it. All right, I think we're ready to wrap it, Mary.
All righty. Well, thank you very much, everyone, for joining us today. Again, the information will be available on our website and will be sent as links to those who have registered today. We appreciate your time in joining us and look forward to seeing you either at the conference or at a future event. Thank you.